You are welcome to my channel. Thanks for visiting. Again, we'll be going over respiratory failure, and I'll be limiting myself to only type 2 respiratory failure. Without further ado, let's go and find out what type 2 respiratory failure is all about. Let's define some terms before delving deeper into type 2 respiratory failure. Respiratory failure is about the derangement in the normal process of inhaling oxygen and exhaling carbon dioxide. That process is impaired when we are talking about respiratory failure. Meaning, is either we are not ventilating fully, leading to decreased supply of oxygen to the blood, that is hypoxemia, that will lead to decrease of oxygen supply to the tissues or all organs, called hypoxia. We are faced with metabolic derangement, and kidneys will be recruited to help because decreased oxygenation and sometimes increased carbon dioxide, as we find out in type 2, will lead to a drop in the pH. That is respiratory acidosis. So kidney will be employed to help so as to compensate by pumping more bicarbonate into the system. Increase low level of pH, meaning acidotic condition, is detrimental to anyone's health. So when we are faced with that, then we are in respiratory failure. Type 1 of that is called hypoxic respiratory failure. And I will not waste your time here going into details of that, because here is the link for type 1 respiratory failure already published by me. You can just copy this link and then you watch it. Now, it is type 2. That is hypercapnia, or there's decreased ventilation. What is hypercapnia all about? We'll find out in a bit. Well, let me just whet your appetite right now that here you are having more carbon dioxide being retained. You are not exhaling enough of it, and that is a sign that the respiratory system is failing. That is type 2. Type 3 is operation related, meaning around the time of operation. We'll go into details when it is the time. Type 4, meaning type 4 respiratory failure, is all about shock, giving all the organs of the body a condition called hypoperfusion. So it's either cardiogenic shock, septic shock, hypovolemic shock, with multiple organ failure, and one of those organs that will be failing would be the respiratory system. So when shock is leading to respiratory organ failure, we call that type 4 respiratory failure. Now, type 2 respiratory failure proper. There's hypercapnia here, meaning there is increased level of CO2. CO2 is being retained. Carbon dioxide is being retained because it's not getting out enough. Oxygen level is also dropping, but maybe normal. Mostly is going to drop. Okay? Here, some people call this ventilatory pump failure. That's another name for type 2 respiratory failure. The decreased level of oxygen here, particularly partial pressure oxygen, is going to be less than 60 millimeters of mercury, mostly. Here, we'll be battling with alveolar ventilatory impairment, affecting the two gases, both CO2 and O2, that is carbon dioxide and oxygen. Like I've said earlier, we are retaining more carbon dioxide. So the level of carbon dioxide will rise. The pressure of CO2 will be greater than 50 millimeters of mercury. Normally, it should be between 34 and 45 millimeters of mercury. This is very common to people with COPD, okay, chronic obstructive pulmonary disease. So the O2 sat in them that will give us concern is anything less than 88%. If we are able to pick 88 to 92%, we are fine. And like I said, the partial pressure of oxygen will drop most of the time, but sometimes it could be within normal range. Remember, the normal one for a partial pressure of oxygen should be between 75 and 100. Here, you could see that it's less than 60 millimeters of mercury. That is what we are going to pick mostly in type 2 respiratory failure, but sometimes might be within the normal range. So here we are dealing with difficulty breathing, and we will ask ourselves, is there difficulty breathing here? So CO2 has been produced through body metabolic activities, but it is not being sufficiently exhaled. Why that? Is airflow already obstructed? Is this person a chronic retainer like COPD patient? Is the use of accessory muscles of respiration in use here? Are we battling with either central chemoreceptors and peripheral chemoreceptors malfunctioning, leading to decreased respiratory drive, or we are dealing with some disease-related conditions like, central nervous system injury somewhere, the muscles are having problems somewhere, the obstruction is obvious somewhere. We'll go into causes in a bit. So we will do a better job finding out what is happening quickly and carrying out appropriate interventions. Possible causes of type 2 respiratory failure. In summary, all we are talking about when it comes to type 2 is carbon dioxide is being produced. But unfortunately, there are so many conditions leading to inadequate or insufficient exhalation of that carbon dioxide. So the carbon dioxide is accumulating, and that is called hypercapnia. That is our problem. Now, let's find out what could be responsible. We should first of all check, is there a decrease in respiration here? We must find out. But remember, in COPD, they will have shallow, rapid respiration that is not effectively getting the CO2 from the alveoli. So, decrease alveolar ventilation, right? So, we will find out again, are we battling with some diseases like I have repeatedly mentioned COPD? But that is not the only condition. We can be dealing with pulmonary embolism. We might be having lung fibrosis. It might be asthma that is troublesome, okay? It might even be COVID or decreased blood flow to the respiratory system as a result of trouble with the cardiovascular system, cardiogenic in origin, when we have decreased cardiac output. And then we will consider some other possible issues like any problem with emotions, like Guillain-Barré syndrome, myasthenia gravis, ALS. We want to find out whether that is what we are dealing with. Then we want to know, are we in trouble with any part of the central nervous system, particularly medulla oblongata, that is no longer sensing what is going on, because that is where the central chemoreceptors are located and where decisions will be taken and message will be sent to peripheral chemoreceptors. So if that is the case, increase level of CO2 and we are not getting any drive and there is no instruction to increase breathing to the extent of exhaling the CO2, man, we are going to keep that CO2 in there, and that is detrimental. Are we having trouble with certain medications right now that is depressing the respiratory system? No. Is this person on narcotics, anesthetic agents, and so on? Then we will have physical examination done. We want to find out any trouble with the ribs of this individual, like flare chest, rib fractures, giving pain. This patient is afraid to even breathe in and out. We want to know about that. Then, is there scoliosis here that is pretty bad? How about kyphosis? How about kyphoscoliosis? We want to know. And we want to see the body mass index. We'll weigh, we'll measure, we'll tabulate, we'll look physically also to see the level of obesity or not. And is this individual having polyneuropathy or there's suffocation anywhere? And it might even be autoimmune condition like ankylosing spondylitis. In that case, when we find one autoimmune condition, we have to look for other autoimmune conditions. Then, when we are done finding out about all these, then we will start thinking about how to get out. Okay, we must first of all check the airway. We'll check the airway for any foreign body or secretion, and we're going to sanction as it is appropriate. Then, we'll give oxygen. Even before contacting pulmonologists, give oxygen first and treat whatever is treatable, like fever, sepsis, burns, and we must always be preventing COPD exacerbation in any patient with COPD. That's why we'll continue to advise that they take their vaccination appropriately. Then we'll inform pulmonologists or neurologist or surgeon as the case might be based on what we have been able to find out as the cause or causes here. So we'll continue after sending the consult and we'll do some brief investigations. Of course, we have to get arterial blood gas and know the level of bicarbonate or get renal function test done to know whether compensation could be achieved or not. If there's pulmonary edema, we go for diuretics, isolin, furosemide, laxatives. We must rule out pulmonary embolism and treat appropriately if that is the case. Is there central nervous system lesion here? Neurologists will help out. How about some conditions, Guillain-Barré syndrome, ALS, etc., it must be addressed appropriately. If it is asthma, okay, it's expected to be reversible. Inhaled corticosteroids, salbutamol, ipratropium, as it is appropriate. Then, COPD exacerbation, if that is the case, we treat. Of course, with the help of the pulmonologist, mechanical ventilation should be in place as may be advised. And we may not be able to leave out the orthopedic surgeon if that is necessary, particularly the deformity or flare chest. So we will do what is appropriate under the guidance of experts. And we must not delay in helping. However, I will not forget to say this before ending this presentation. Type 2 respiratory failure is pretty common. with individuals who have been diagnosed with chronic obstructive pulmonary disease. The most important thing is to help them not to have acute exacerbation. So we guide them, okay, what to do away with and what to incorporate, vaccination and so on. Our target of O2 sat in them is 88% to 92%. It is not appropriate to keep pumping them with oxygen because that will kill the hypoxic drive that will help them to breathe. Thanks for listening. Please remember to subscribe to my channel. Type 3 respiratory failure will soon be published. I appreciate it.